Hi guys, thank you for joining me on today's Fertility Expert Q&A series. I'm super excited to have Dr. Nidhee Sachdev on today's show. We got so many awesome questions from all over the world, and I'm super excited to review them, talk to her about them, see what she thinks. One of the greatest things about these live Q&As is that you get to hear perspectives from two different fertility experts and hear how we do things, and that's what I love about this. And I love that the questions are growing, the viewership is growing, and we just hope to do these more and more. So I'm super excited to bring her on. Let's see here. Hi, everybody. There she is. Awesome. And thank you guys for sending your questions. You can feel free to chat us live. Hi, Nidhee. Nice to see you. Thanks for being available today. Super excited to do this with you.
Yeah, Dr. Amy, I'm excited to be here with you.
Awesome. So tell us about yourself for people who are just getting to know you a little bit more. Tell us about your clinic, where you live, all that good stuff.
Yeah, cool. All right. So my name is Dr. Nidhee Sachdev. My patients call me Dr. S. I'm here in Newport Beach in Orange County, and I practice at OC Fertility. We're part of the CCRM network. So the lab that we use is CCRM Orange County.
Okay. Sounds amazing. Are you ready for all the questions?
I think so. Let's do
it. Okay. So here we go. Question for your Q&A today. I've been trying to conceive baby number 2 for 15 months and had an ectopic pregnancy last September and had my right tube removed. Wondering if IUI is worth trying before moving to IVF, or should I go straight to IVF? What do you think?
Okay. Well, I'm sorry to hear you had an ectopic. I know that's kind of rough. So here's the deal. When you ovulate every month, you may ovulate from the same side. You may not ovulate from the same side. You may alternate. So when doing an IUI cycle, an ovulation induction, it's possible that you may ovulate from the side that you don't have a tube, or you may ovulate from both sides. So when deciding what to do, you kind of have to decide, okay, am I okay going the conservative route and doing an ovulation induction cycle, knowing that there's a chance I may ovulate from the side that I don't have a tube. Even if you do ovulate from the side you don't have a tube, there's technically a 30% chance the other side can scoop it up, but that's 30%. So I talk to the patients, I talk about their age, how long they've been trying, and kind of their mental and emotional stamina. I mean, I would recommend moving towards IVF sooner rather than later, but for some people, they feel kind of rushed into going to IVF first. So I don't think it's a bad option to do an ovulation induction IUI cycle, but I do think IVF might be in the cards if you essentially are limiting your chances of getting pregnant by about 50%.
Absolutely. And here's another part to this question too. Also, have you seen women get pregnant soon after the HSG procedure? My doctor suggested doing it to check my left tube before doing an IUI next month. I already did Clomid for 3 months and didn't get pregnant. And then my lining started to become affected and I stopped to give my body a break. What do you think about that part of the question?
Yeah, so it's been shown that when you do an HSG, you're actually more fertile in the few months afterwards, because if there's any sort of blood or debris within, the dye that's used to see if your tubes are open or patent kind of flushes it out. So it might actually help. So I've definitely seen patients get pregnant the month that they do it or the month afterwards. Yeah. So if your doctor thinks it's warranted and you don't mind going through it, I would definitely recommend you do it.
Yeah, I totally agree. And I think especially after you've had an ectopic pregnancy, it's super important to make sure that the other tube is open as well. I mean, even though it sounds like this person who's asking us this question had a pregnancy in her uterus before, but you know, things can happen and things can certainly change. And hopefully that left tube is open for her. Great question. So here's another one. Hi there. Can you talk about Clomid versus letrozole? For those of you who don't know what letrozole is, it's also known as Femara. I was put on letrozole and had all the side effects, muscle pains, headaches. So now we're trying Clomid 100 milligrams. So far, no side effects. We're trying for super ovulation because I don't ovulate. It's just really late as day 23 or so. So what do you think between Clomid or letrozole?
Good question. So Clomid and letrozole function the same way. Mechanistically, they're a little bit different, but the goal is to make our body think that we're not growing any eggs. So our body says, oh, we're not growing any eggs. Let's try to grow more eggs, with the goal that maybe instead of getting just 1 every month, maybe we'll get 2, maybe we'll get 3. The goal is not really to get 8. The goal is to just increase our odds a little bit. So studies have shown that if a person has PCOS, that letrozole might be a little bit better than Clomid. But if you don't have symptoms of PCOS, the standard of care for a lot of people is actually Clomid. The problem is that some people will have symptoms with Clomid, and one symptom that they can have is that it thins out their lining. Mm-hmm. So you kind of have to, if that happens to patients, then we'll switch them to letrozole. It sounds like in your case, it was the opposite. You tried letrozole and you had symptoms. So I don't think it's a bad idea to go with letrozole. I think that it's a good option, with Clomid. But if it does thin the lining, one thing you can do is you can add in vaginal estrogen or a form of estrogen to kind of help that. So if I know that's happened to patients in the past and another option isn't available, such as letrozole because of symptoms, I'll bring them back a little bit early. Once I see them start to develop a follicle, I'll add in the vaginal estrogen so that it doesn't interfere with the follicle growing, and then it can kind of help supplement that lining to help make it a little bit bigger.
I agree. And I call Clomid Clo Monster, and I tell patients if you want it, you have to schedule your exorcism next. I mean, come on. It can make you feel a little nutty, but not
Totally.
for everybody, but certainly for some people. So I like to start, with letrozole first, but I agree. Clomid can definitely work unless it thins out your lining. Okay.
Totally.
Great approach by adding the estrogen. I totally agree. Okay. So here are questions about day 7 blastocysts. Okay. So for those of you, why don't you tell us, tell us what's a blastocyst, what's day 5, day 6, day 7?
Yeah, totally. Okay, so whether you're doing IVF or trying to get pregnant on your own, there's steps that need to occur. Obviously, the egg and the sperm need to meet, then they fertilize, then they slowly grow and divide. So you start off with 1 cells that then become 2, which then divide to become 4, 8, 16, and so on. Over the course of about a week, the embryo develops and grows to become a more mature embryo that we call a blastocyst. It consists of fluid within the cavity, which is called the blastocele cavity. So it's called a blastocyst because it has cells on the outside of it, and it has a tightly compacted cells in the middle. So the outer cells are called trivectoderm. They actually go on to become the placenta, whereas the tightly group of cells is called the inner cell mass. That goes on to become the baby. And so a blastocyst takes time to develop over the course of 5 to 7 days. And in the IVF lab, after the egg and the sperm fertilize, they're left in the dish and we watch them grow. So typically after they fertilize, we'll evaluate them maybe on day 3, but again on day 5, 6, and 7. Mm-hmm. And as these cells fertilize, some of them grow at different rates. So some will become a blastocyst by day 5, whereas some might become blastocysts on day 6 or in day 7. Right. So I think the question was asking about day 7 mm-hmm. and how does it differ in comparison to day 5? And what that means is that it took that egg and that sperm that fertilized an extra 2 days to grow and become expanded to be called a blastocyst.
Mm-hmm. Right. Yeah. Keep going. I love it. Keep riffing about day 7. I'm going to ask you the questions in this question, but keep going.
Yeah. So I have a lot of patients that say, oh, shoot, I got a day 7. What does that mean? So again, it just means that embryo took longer to grow and to develop. Right. Now, inherently, embryos that become blastocysts on day 5 are thought to be a little bit better than the ones that become blastocysts on day 6 and day 7. But a day 7 embryo still has the potential to become a baby. It depends on what you're doing. So we will often biopsy our embryos. Mm-hmm. And so studies have shown that if you biopsy an embryo on day 5, day 6, and day 7, they all have the potential to be normal embryos or euploid embryos. But the day 7 embryos might have the percentage of embryos on day 7 that are chromosomally normal are a little bit less. Right. And the same thing for implantation. The implantation rates for day 7 have been shown that they might be a little bit less, but when looking at studies, a lot of them show that there's no statistical significance, meaning that maybe they were less due to chance, not necessarily that they truly have a lower implantation potential.
Right. So don't count your day 7 embryos out.
Totally. You worked hard to make those.
Yeah, exactly. Yeah. So here are the questions. Do most clinics let embryos grow till day 7? What is your thought and experience with that from what you've seen?
Yeah. I think that as we're learning more about IVF, I think more and more clinics are growing them out until day 7 because they're learning that some people just take longer to grow and to develop. Yeah. And even sometimes, depending upon occasionally if we have an egg that's immature and we let it mature overnight and then we fertilize it a day later, we'll let that grow out a day later to day 8 sometimes. And I actually did a paper on this when I was in fellowship that showed that if you biopsy an embryo on day 8, yeah, it has a lower chance of it being chromosomally normal, but those embryos still make babies.
Wow. Day 8? Seriously?
Yeah. Yeah. It was a small case study, but there was 3 and actually one of them split to make monozygotic twins. So 4 babies from 3 day 8 embryos.
Amazing. Okay. Here's another question. What percentage of day 7 embryos are found to be PGT normal? What do you think?
It's a little bit lower. I would say some studies say that it's about like the high 40%. 40 to 47%, whereas day 5s might be like in the 60%, and day 6 might be in the low 60s, high 50s.
Right. And of course, it depends on your age for sure.
Totally.
Too.
Yeah.
Okay. So why would a day 7 embryo have a lower implantation rate than, let's say, a day 5 or a day 6?
So the thought is just that if it's taking longer to develop, there's a chance that there could be some underlying mechanism within it that is not going to lend to it implanting well. Right. So I think that's the thing. But again, don't count it out.
Okay. So it probably has to do with energy. energy, but still don't count it out. Great. So here's another question for you. I'm also of Indian descent. And do you have any suggestions for Indian women when it comes to prepping for egg freezing? Things to eat, not to eat, to do, not to do, look out for. Thank you so much.
Yeah, no worries. Okay. So I think when prepping for an egg freeze cycle, it's similar to prepping for an IVF cycle. You want to
Mhm.
optimize your chances of having good eggs and good egg quality. So I always counsel patients that diet and exercise are key and important. And so we have a lot of roti, which are, I don't know if you ever had a roti Indian food. It's made of like whole wheat dough and different types of dough. So, but it's carbs, it's bread. There's a lot of rice in our curries. That's important. Oils.
Mhm.
So you don't want to have a lot of starches and things. So if you can kind of clean up your diet and optimize it in the months leading up to it, that's going to be key. Those
So
are
what would
probably
be
the
a good replacement for roti?
lettuce.
Lettuce.
It's hard to
Big
do.
green, big
Yeah,
leaves, big leaves.
yeah.
My aunt always says, you need to eat big leaves. I said, okay, big leaves.
Yeah,
Yeah.
so but like if you get a big lettuce, you can
Yeah.
still have the same mechanism. You got like the mechanism ripping it and dipping it.
Right.
You can still have the same mechanism of doing it, and it's not in the beginning it's not as satisfying, but I've done it. It's actually
Good.
it works out pretty well.
Okay. What other tips? I didn't mean to cut you off. This is good.
No, I mean, I would say that's the main one, diet
Okay.
and exercise. And then other things, you want to make sure you're limiting, like your alcohol intake. I wouldn't kind of drink excessively, limiting any smoking, vaping, or hookah.
Yeah.
Those are
And
big
then what
things.
about brown rice? Someone's asking about brown rice.
Brown rice it's still a carb. I would say it's an improvement over white rice.
Right.
I wouldn't say you have to completely cut out the carbs because that may not be possible. But yeah, I
Right.
would switch from white to brown rice. That's a good thought.
Got it. Okay. Here's another question. Hi, thank you so much for doing this. I'm 31 years old, trying to conceive for 2 years with 2 miscarriages. One was confirmed abnormal at 13 weeks. Both of those times I spontaneously got pregnant, but it took 2 months, 6 months and 9 months with each pregnancy. My cycle is very long, anywhere from 31 to 39 days, ovulating around 23-ish a lot of the time. I know I ovulate because I obtained the positive OPK test and then get my period 14 days later. Here's the question. I have a very high antral follicle count at 49 follicles. Any way to shorten my cycle so I ovulate sooner? I just feel like I have to wait triple the time of other people to try and get pregnant.
Yes, totally. So yeah, so when people have longer cycles, yeah, when someone ovulates on day 14, you're ovulating on day 23. If you add that up every month, you're missing out
Right.
on 1 to 2 cycles, right? So
Right.
what are things that you can do?
Nidhee, I just lost you for a second. You broke,
Can you hear
you
me?
lost your sound there. Now I can hear you. Can you start over with that answer? I want to make sure we get that because I'm sure it
Yeah,
was
totally.
amazing. Yeah.
Yeah. Okay, so it's about regulating your cycle. Someone who's
Hmm.
got a ovulates later,
Yeah.
if you add that up over the course of a year, you're missing out on cycles. So diet and exercise are key in optimizing your
You're freezing up again, Nidhee. You just froze again.
PCOS.
Uh-huh. You just froze
What about
there
now?
just for a second. So you were
Can you see
just
me now?
talking about PCOS. Yeah, I can see you great.
Okay,
Yeah, I
perfect.
can see you great. Yeah. Yeah. So
Perfect. All
the
right.
question is
So,
49
diet
follicles,
and
long
exercise.
cycles. Yeah, diet and exercise.
So it sounds like that person probably has PCOS.
Right.
So diet and exercise are key. Sometimes there's a sweet spot for your weight.
Mm-hmm.
So I counsel patients that if you can like lose maybe 5% of your body weight, which is sometimes 5, sometimes 10 pounds, that can really regulate it. For some patients in which that's, they're trying and that's not really working, we could talk about it possibly adding on metformin.
Mm-hmm.
That can sometimes help regulate your cycles.
Right. I agree. Figure out why your cycles are so long and treat that. If it's PCOS, what's the hormonal imbalance and treat that imbalance with
Yeah.
supplements. You can add Femera or Clomid, whichever you think is right for you. So someone asked a
Yeah.
question. Does seeing an Ayurvedic practitioner, is that a good idea to optimize fertility before IVF?
That's a great question. I think that's a good option if that's something that's available to you. I think the one thing we get is that there's not just one approach to medicine. There's multiple different avenues. And so if you can have someone help you with your Ayurvedic on the Ayurvedic side, I think that's
Mm-hmm.
only going to help. That can,
Mm-hmm.
again, help clean up your diet, can help give you tips on nutrition and things of that
Yeah.
sort, which will be helpful.
Yeah. Okay. Awesome. So here are some more questions. This is from someone else. And she starts off with saying, thank you so much for doing this. Here are my questions. Why do some people go on birth control pills before their frozen embryo transfer? And that's part 1 of 5 questions for you.
Okay. So one, it could be for timing purposes. Okay. Two, it depends on the protocol. So some protocols that we use involve Lupron on it.
Mhm.
And in order to use Lupron to suppress you, you have to suppress your ovaries first.
Right.
So you start off by suppressing you by being on the birth control pill for at least 7 to 10 days. Because if you give Lupron without being suppressed, it can actually cause a flare and cause your ovaries to act up. So we put you on Lupron for about a week to 2 weeks and then overlap it with the Lupron and then continue with the cycle.
Perfect. Yeah. And the reason why we're doing that is we're trying to mimic ovulation. And if your ovaries get in the way,
Yes.
that causes all sorts of problems with us trying to, time things perfectly. And what I tell patients is this, I say, birth control pills are like wearing a belt, right? People look at me like, huh? I'm not very good at this. So follow me. So when you're wearing a belt, your pants don't fall off. And that's kind of like ovulation, right? So your pants falling off during an IVF cycle is like annoying, like your pants falling off if they fall off. So Lupron's like wearing suspenders, right? So when you wear a belt, sometimes your pants still fall off, but if you put those suspenders on, your pants are not going to fall off. Okay, great. Okay, here's the next question. How important is embryo grading?
So that is a good question. So what is an embryo grade? So when an embryologist is looking at an embryo, they're looking at the overall shape and how expanded that embryo is, the blastocyst. Then they're looking at the two types of cells. I mentioned the tightly compacted cells that become the baby, the inner cell mass, and the cells on the outside called the trophectoderm. And depending upon the lab, but the majority of them will give them grades like in school, A through D, right? Obviously, A is better than D, but they use that to visually estimate which ones they think look a little bit better. And those grades are associated with implantation potential, not the health of the baby, but not really whether they're chromosomally normal or not, but the implantation potential. So they are helpful, but they're all just kind of selection tools to help us identify which embryo to transfer. If you're testing the embryos, then obviously whether they're chromosomally normal or not, that trumps the grade.
Right.
But if you're deciding which embryo to transfer, then if you have embryo 1, 2, and 3, which are all chromosomally normal, and gender is not something that we're choosing from, then we can use the grades to decide. But I usually tell patients that the grades are helpful, but they're not the end all be all. I've had embryos that made beautiful babies that one could argue weren't the prettiest looking embryos.
I agree.
So you got to take everything with a grain of salt, I tell everybody.
Absolutely. And I call embryos, here it goes with my analogies. They're kind of like diamonds, right? You just see how beautiful they are. But unlike diamonds, the beauty on the outside is not equivalent to the beauty on the inside until you transfer it and see what happens. So we get this question a lot. Is there a difference in live birth rates for day 5 and day 6 embryos? And we've had other experts come on and say that there is a difference. So what is it like in your lab?
In our lab, there is, I would say, so we don't have day 5 or day 6. We have tiers essentially, and it's not always that a day 5 isn't always inherently better than a day 6. But if the grades are equivalent, we'll transfer the day 5 before the day 6. And the implantation rates differ, but not significantly. I would say by about 5%.
Yeah, exactly. And every lab's different. Some labs it's 1%. Some labs it's no percent. I know that there are labs that don't see a difference in their pregnancy rates between day 5 and day 6.
Like I'll have patients say, I want to transfer my second best embryo instead of my first. And if it's a day 5 versus day 6, I'm like, yeah, let's do it. Go for it. Whatever makes you feel better and makes you, in a better place.
Exactly. Okay. Here's another question about the ERA test. What are your thoughts on it? And what if you want to do it, but your REI doctor is not supportive?
That's a good question because I get that a fair amount. Okay. The ERA stands for the endometrial receptivity assay. Okay. And it's designed for patients who have gone through embryo transfers that have failed. And the point of it is that you mimic an embryo transfer cycle. It's supposed to be an apples to apples comparison. You do the cycle like you would do a transfer. You take the hormones, you take the progesterone, and on the day that you would do a transfer, you do an endometrial biopsy. And then you take that sample and it's sent off to a lab. And they're looking at the samples to see which genes are expressed at that time to say, hey, does your uterus have the genes necessary for implantation when you've received that many days of progesterone? Okay, because for some people, they need more progesterone, right? And some people, they need less progesterone. So I usually talk to patients and say, it depends on your clinical situation. Usually, I won't recommend it for everybody, but it depends. If you've had a failed embryo transfer and then you're deciding whether to do another one, I'll say, well, it depends. If someone's 41 and they only have one left, then yeah, I'll recommend it. Right. If they have 5 embryos left and they're 31, not that we don't take every embryo seriously, but we'll say, we'll look at the, the risk benefit analysis. I say, hey, I expect about 80% of the patients to not find a difference. Okay. Could you be one of the 20%? It's possible. But, so I usually say if you have many embryos and you're young, maybe let's try two, because
Right.
anybody can fail one embryo transfer,
Right.
right? Yeah, there's statistics, but ultimately the results are binary, zero
Right.
or 100%. You either work and you get a baby or you don't.
Right.
So I say anybody can fail one. Not everybody fails two.
Right.
So after two, I started talking to them more seriously about it. It's hard because, there's evidence-based medicine, and some of the evidence may not go towards doing it after one. But that's the hard part about what we do, is that,
Right.
this is the change. We're changing the trajectory of people's lives. So it's hard to say, to put people into boxes and say, no, you have to fail two before you do them.
Right. Right.
So, I would advocate that, you advocate to your doctor as to why you find it important, and
Right.
hear what they have to say and talk about the pros and cons of it, and then make a decision.
Absolutely. And then here's another ERA question that we just got chatted live. I just want to ask it now because it seems like the timing is right. Once you do an ERA test, can those results be used for all future transfers, or must the test be done again? What is your style?
So I will use it, but after they've had a baby, sometimes I repeat it because it's
Mhm.
not clear after delivery if your endometrial receptivity can change. And I've actually reached out to them and talked to them about it, and they said the data is inconclusive. So depending upon the history and how old the person is and their age and how many embryos we have, I might repeat it if they're amenable to it.
I agree. I'm right there with you. And I look again and see how many embryos they have left. How
Yeah,
old are they? If this transfer doesn't
yeah,
work, we always talk about what we're going to do differently if this
yeah.
transfer isn't successful. Awesome. So here's another question. Hi there. I just did an IUI cycle with letrozole and it didn't work.
Oh, I'm
My
sorry.
doctor is switching me to Clomid since I had bad side effects on letrozole. It sounds like everyone, I hear the opposite. Everyone's having bad side effects on Clomid. Today, everyone's
Yeah,
calling us and or
yeah,
messaging me about bad side effects on letrozole. Poor letrozole.
yeah.
However, she didn't have me come in for a baseline ultrasound before starting to check for cysts. And I've never had cysts in my life that I know of. But I've heard a lot from other women who've gone through fertility treatments, and they all get a cyst check done before starting another IUI cycle. Should I be concerned that my doctor does not want to do it? That's her question. What is your style?
So, 10% of all women who get Clomid may get, might have some cysts after their cycle. So
Mhm.
we routinely will do it, but I trained at places where we didn't routinely do it, and I don't think the outcomes were significantly different. One, I think for me, it's part of a way to make sure that also that the patient has their instructions, they know what to do, and to rule out pregnancy. Sometimes patients can have a negative pregnancy test and have irregular bleeding, and then we find out that it's an ectopic.
Right.
So I think sometimes it's just whatever each clinic is comfortable with. I wouldn't stress out too much about it.
Yeah.
Because there's not over 90% chance that you don't have cysts and you've never had cysts in the
Right.
past. Typically, if someone has cysts, it's usually after the first cycle, they'll come back and we'll see that they have cysts.
Right.
But I think it's okay. But if in the future, if you want one, you can talk to your doctor about it, and I'm sure they would be more than happy to do it.
Yeah, that's exactly what I said. If you feel like you want a cyst check, go have a cyst check, And for
Yeah,
me, I always do it if a patient ovulated more than 2 eggs in the previous cycle. I don't automatically do it. I do it if I'm tracking and trending FSH estradiol levels, or I'm thinking that I might want to convert an IUI to an IVF cycle. And a lot of my
yeah,
patients do that because we're trying to maximize our chances and see what we're going to get each cycle. And sometimes I
yeah,
start off saying, let's just be aggressive and see what happens and just be open to either IUI or IVF. But I'm totally with
totally.
you.
Yeah.
Okay, here's a question from somebody else. Hi, a question for your show today. I just had my third embryo transfer this past Friday, and between the time the picture of the embryo was taken to when it was placed on the TV screen before the transfer, it had completely hatched out. I read mixed things online. In your experience, is a completely hatched embryo a good thing or a bad thing?
Ultimately, the embryo needs to hatch.
Right.
So I think it's a good thing.
Yeah.
Part of implantation is that the embryo needs to get out of that shell, the zona pellucida, to attach. I think the studies have shown that if it completely hatches, the concern is that maybe there could be some issue during the transfer. But truthfully, our catheters are really good.
Yes.
Our fluid media is good. We've learned so much.
Mm-hmm.
Ultimately, it's a good thing. That means that embryo was ready and waiting to find its home.
Right. It's ready to stick and grow since it's already
Yes.
hatched. It's ready to attach and
Yes.
stick and grow. So this is a cute
Yes.
question. What do you think about sperm meets egg method? And I have a feeling what that means is either like having sex, which I think is pretty awesome and way more romantic than anything that can happen in my office, or probably IVF without ICSI. So what do you prefer? And don't answer the sex part. Kidding.
I I think the question is, it's a question more like IVF with ICSI, like from like a Darwin standpoint, what makes a
Right,
difference, like
exactly.
natural selection versus,
Right, exactly.
I get that question a lot, and patients
Right,
are like, how do you know that you're going to choose the right sperm
right,
versus letting natural selection happen?
right,
And the short of the answer is you don't know,
right.
but ultimately, there's a pool of eggs there. And, when they're choosing a sperm, they're looking at one that visually looks good, that is moving well. And ultimately, that's what natural selection is, right? The one that looks well and that moves well. So I think the outcomes are comparable.
Yeah, I agree. I mean, I just tell people that if you don't already have a baby at home, you don't know fertilization is issue. I don't want to go through your cycle and then just say, well, next time we're going to try ICSI. You want to
Yeah.
talk through all those things. And I'm sure you do some advanced sperm stuff too, like DNA fragmentation testing ahead of your cycles, and also do PICSI or Zymo or, other things to pick the very best sperm cell too.
Yeah, we do a lot. We do all that stuff.
Yeah.
A lot of our cycles are, we do embryo testing. So for
Right.
all the embryo testing, we do ICSI.
Right.
And it just depends. I've seen the majority of our patients do get ICSI, just depends on their circumstance. Even if they're not doing testing, oftentimes it might be because we just don't have very many eggs, or it might be a sperm issue. So to optimize fertilization, we're going to do all that stuff.
Right. Okay. Here's another great question. Thank you for sharing valuable. I can talk, I promise. Information and insights with women struggling with infertility. You're welcome. I recently underwent an egg retrieval and ended up with all day 7 blastocysts. Here's another question about day 7 blastocysts. I was wondering if you would consider doing an episode on day 7. Well, we're kind of doing an episode on day 7 blastocysts. There's very little information. Okay, well, that was just a comment. I just read that. Well, we already did the day 7 question, so that's great. Okay. Hi. Question for your live. Do REs usually prescribe, do fertility doctors usually prescribe omnitrope? And for those of you who don't know what that is, that's HGH, for their first cycle IVF if egg quality is a problem? Or is it used mainly, you know what I'm saying? Let's talk to me about omnitrope, HGH. Yeah. When do you use it? And I'll talk about when I use it and your approach. Do you use it the first cycle? Do you wait and see if egg quality is an issue? What do you do?
So I'll use it if I think that egg quality is going to be an issue, if age is going to be an issue, if they have a low ovarian reserve or low antral follicle count. If I think that we're kind of in an uphill battle, I'll add it on. If I have no reason to believe that, I typically don't start with it, but I usually add it on at the time during the stim. I don't pre-treat with it, so I usually add it on. And so depending upon how the cycle is going, sometimes I might make a game time decision and add it on. Like if they're not responding as well, I will, because it's fairly easy to get. We can get same day delivery. So yeah, but routinely, I will add it on the first cycle if I'm concerned about their ovarian reserve or their egg quality.
Yeah, I agree. I recommend to anyone who has an elevated FSH, anyone who's done a prior cycle, even if they don't have an elevated FSH or any suspicion, just egg quality wise, I add it on. And I also have patients maybe start it for 1 to 2 months before. I think in some people, and I'm sure it's related to their genes, something in their genes that maybe there might be a cumulative benefit for some people, and I don't see it in others. So I've seen some pretty tremendous results. Okay, here's another question. Let's see here. Okay. I'm curious about what to expect once I'm pregnant after IVF. I feel really lost. I feel like when I talk to my doctor, all he does is text and say, keep on with the medication. See you next week.
So, okay, pregnancy when you are undergoing IVF is comparable, except you got a lot more baggage. You got a lot more shots you're still taking. You got a lot of meds. You got a lot more appointments. So we'll routinely follow our patients every week until 12 weeks. So in the beginning, once you're pregnant, when you do a pregnancy test, if it's positive, we'll repeat it every 2 days to make sure it's rising appropriately. Then we do our first scan at 5 weeks. And so at every ultrasound, we'll see some milestones. At 5 weeks, we really just expect to see a gestational sac to make sure that the pregnancy is in the uterus. Then at 6 weeks, we'll expect to see a gestational sac, something called a yolk sac, and a tiny little fetal pole. Yeah. And sometimes you'll be able to see a little flicker of a heartbeat, which is really nice. Yeah. 7 weeks, that fetal pole gets a little bit bigger and the fetal heartbeat is audible. And then by 8 weeks, you just see that fetal pole start growing. Yeah. And so typically we will start to slowly wean you off your medication, starting around between 7 and 8 weeks, depending on your medical history. And with our goal, and every place varies, to get you off all your meds by about 10 weeks, plus or minus.
You're very nice that you start weaning at 7. I'm not that nice.
We don't wean the progesterone. We wean various forms. The progesterone we wean at 9. Yeah.
No, that makes sense.
Yeah. We do the shots we wean at 9
I just
weeks.
don't want everyone to be going to you thinking that we're going to be getting weaned off.
No.
I don't think so.
Yeah.
Okay.
So yeah, so then at around 8 weeks, we say, hey, call your OB, tell them you're coming in a few weeks. At 10 weeks, we offer the NIPT test, the non-invasive prenatal testing. That's a blood test that we get from you that can assess the fetal cells to assess if the pregnancy is chromosomally normal. It screens for, the most common chromosomal abnormality like Down syndrome, trisomy 13 and 18. It can also identify the gender.
Right.
Even for patients who underwent IVF with PGT, we still recommend it because I say, hey, once you're pregnant, yes, you're taking meds and shots, but you should be treated like you got pregnant on your own. So, I still recommend all the screening tests. And so we'll confirm the gender. For those who don't know, they might find out the gender at that time. And then at 12 weeks, you graduate to your OB.
Do you ever have patients who say, can you send my local baker my gender, or call my sister for the gender?
Oh, totally. Yeah. We have like little gender reveal cards.
And
then, that we have. And then like sometimes we'll like email, like they'll be like, hey, can you email this person via Etsy? Right. Or we have patients who have like golf balls. And so they're like, hey, here's the one, give us back the right color. Because they have little labels and stuff. Yeah. So we do all sorts of fun stuff.
Yeah. So I had a patient tell me once that she ordered her cake, and when she picked it up, the gender was on the receipt. So I always warn patients, I'm like, don't pick up your own cake.
I had a patient who cut it and they couldn't tell the color. It was like so pale. Then they had to call and be like, what's the color? So I always advise against the cake.
Yeah, that's funny. That's a good reason to advise against it. Okay, here's another question. Hi, you two. I'm distraught. I had ICSI done last October, 10 eggs retrieved, all died after ICSI, even though I was told I had good quality eggs. 2 months later, I got pregnant naturally, but it was a blighted ovum and I miscarried. I'm worried I'll never get pregnant now if ICSI failed. What do you think? What can I do?
Oh, I'm sorry.
I know.
So what I would recommend is try again, right? So when fertilization failed, it could be the sperm, it could be the egg. We're not 100% sure. I would make sure that there's adequate sperm count, and I would have testing done. I think that's an appropriate time to do DNA fragmentation testing. There's other things, and I would talk to your provider about it to say, okay, do we think are underlying reasons? Could it be that was it just not that much sperm? Was the quality of the sperm an issue? There's something called PIXI, in which they can use to evaluate which sperm are binding to the eggs to see which ones are more likely to fertilize. And there's different things you can try to help maybe improve egg quality. Occasionally, I don't recommend this for all patients, but sometimes we say, for patients, if we think it might be a sperm issue, not an egg, we can talk about possibly donor sperm and splitting the eggs half and half. Not every patient is okay with that or ready for it. It just depends on the situation.
Right. And not to put my paranoid hat on, but I'm going to put it on here. So if she's saying that all 10 eggs died at the time of ICSI, right? And maybe she didn't even get a chance to do ICSI, I would ask, well, did that happen to anyone else in the lab at the same time? Right. And see, maybe there was some sort of media or oil that the eggs touched, and maybe that affected the eggs. And hopefully next time the same thing will not happen and your eggs are actually good and you don't have to worry. But maybe talk to the lab director or talk to your doctor about that and see if the same thing happened to other people on the same day. Because that's what I would be asking if it were me. Okay, so now we're ready for all our live chatted questions. Okay. How are you doing on time? Are you good?
I'm doing good.
Okay, here we go. I'm going to start scrolling through. Thank you guys for all being here. Dr. S is a genetics expert. So if you have genetics questions, please also ask. I see a bunch coming through too. So here's a question. Since my lining was affected by when I took Clomid, my OBGYN suggested letrozole, yay letrozole, or even doing injections of FSH. What do you think of FSH injections instead of letrozole? What would you say?
Good question. So FSH injections can be helpful. The only downside sometimes is that you might develop too many eggs, and it really increases your risk of multiples. So it's a risk-benefit analysis depending upon your age and the number of eggs that you make. Sometimes I will do a combo with letrozole and the injections, but again, sometimes we run the risk of having too many eggs.
Yeah, and that FSH is very expensive. I call it the hybrid protocol. I love overlapping them too.
Yeah.
Little something, something here, something, something there to make our momlet. Okay, here's another question. Hello from Fertility Within Reach. Question from the community. There's a genetic kidney disease that runs in my family. My father died at 34 from that disease. How do I know if I should be screened? I bet you know. Go ahead.
Yeah, so it sounds like that might be something called polycystic kidney disease, which is something that's inherited in an autosomal dominant fashion, which means that, often doesn't skip a generation. So I would see if your father had any testing for that. And if not, I would recommend that you get tested for that. Because in the event that you have that, then there's a possibility that you can pass it on to your offspring. And if that is the case, you might want to consider doing IVF with PGT, M for monogenic disorder, meaning that then they are not only looking for chromosomes, but they're looking for that specific gene within the embryo to identify which embryo has it and could potentially have that disease.
Yeah, we have so many acronyms. I don't think there is any other field of medicine that has as many acronyms as we do.
Oh, probably not.
PGTM, PGTA, IVF, ICSI. It's just, I feel like a rap singer. I need to do a better job rapping. Okay. So this is a question back to the day 7 thing. What if the clinic only looks up to day 6? Could we ask them to look up to day 7 as well? What's your experience with that?
I think it's worth talking to your provider about. It depends on the clinic. It depends on each lab's protocol.
Yeah.
You know, if it's not in their protocol, it might be a little hard to do, but I think it's worth exploring and talking about it and asking what the reasoning for that is. I mean, you know, every lab, no matter who you are, where you are, runs their own internal statistics, and they're constantly trying to improve themselves. So for whatever reason, there might be a reason as to why they were doing that. But I always tell patients that I think it's important that you advocate for yourselves. And, you know, bring up things that are important to you, because there's a million different ways we can do things. And, you know, there's reasons why we do or we don't things. So I think it's worth talking to things about. Maybe maybe that person will change the practice of how that clinic does things and ultimately benefit many others.
Absolutely. And I bet you do the same thing. You want to give every single embryo the benefit of the doubt. But if an embryo isn't alive on day 6, you can tell, right? You can tell if the cells are alive or not alive. And I don't like to say the opposite of not alive. I just like to say not alive.
Yes.
Okay. So I have more questions here. I'm just scrolling through. Thank you guys all for sending them in or chatting them here with us. I'm visiting my, oh no, I just skipped one. There was a really good one here that I just accidentally skipped. I didn't mean to do that. Okay. If you have a history of eggs not making it to blast, why do people think transferring by day 3 is somehow going to change the success of the embryo? What is your style? I know it's definitely doctor dependent on how we answer that question. What do you do?
That's a good question. So it depends on the situation. So the thought is that if the embryo is not growing and dividing within the lab to day 5 and that it's not of a good enough quality to freeze, maybe for that person, you know, not everybody's created equal. Maybe for that person, if you transfer it in their body, that embryo is going to do better. So it depends. If the person is young and it's really unexpected, I might, but oftentimes, sometimes it's just cycle dependent. You know, I'll have patients who just don't do well one cycle, and maybe we'll tweak something the next and it'll be so much different. So I typically don't always transfer on day 3, but I leave it up to the patient and we have a discussion. So it's not common that we do that. But typically after I talk to the patients about pros and cons, we usually don't end up doing it, but I'm open to it. But being honest, it's not a common thing.
Yeah. I mean, I definitely, in some cases, let's say I have a patient who the sperm source is really, really poor quality. And there's just this one variable. We just don't know how the sperm's going to even fertilize the eggs, how the embryos are going to progress. So sometimes I'll have the patient prepared for a possible transfer. But ideally, we want the benefit of learning more about the embryos and culturing them to day 5 and doing genetic testing. So there are definitely cases where you can be prepared for a transfer. But for the most part, I'm right there with you. Right there with you. Okay, here's a great question. And I actually am, I don't know if you can see this, but I think my answer is right here on my cup. It's kind of backwards, but it says, you see what it says. So I'm visiting my GYN this Friday. I've been trying to conceive for a couple months. What questions and tests should I ask my gyno to get started? So how would you answer that question?
Yeah, so I think an important thing is genetic carrier screening that you could do with your gynecologist. That's blood tests that you can do to see, are you a carrier for inheritable diseases, meaning diseases you can pass on to your kids? If you are, then you want to have your partner tested. Also, you can find out if you are a carrier for disease that you alone can pass on to your sons, like through your X chromosome. So that's an important thing. Another thing is if you're thinking about trying to get pregnant is having your ovarian reserve tested. Like your AMH is a value, your anti-Müllerian hormone. That isn't like a marker of your fertility, but it's a marker of your ovarian reserve, and it's useful information that can help. Also, I would say like make sure your vitamin D is up to date, get that checked, and get your thyroid checked. Those are the most important things. And then other important things we do is we make sure you're immune to some communicable diseases that we want you to be immune to before you're pregnant, like rubella, which is the German measles, chicken pox, and the actual measles, and especially in Orange County, that came back for a little bit last summer.
Right, right. So that's where I came up with the Tushy method. TushyMethod.com, people. Tubes, uterus, sperm, hormones, and throw in the preconception panel and your genetics. So exactly right. And sometimes OBs just aren't like, they're awesome, right? OBGYNs in our community are so good, but sometimes this isn't their thing, you know?
Yeah.
So you wouldn't go to your primary care doctor if you had a heart attack necessarily. You would go right to a cardiologist because we have access to cardiologists in our area. So doing preconception testing sometimes can be great if you just go right to a fertility doctor so you can have them review your family size goals, and they can create a roadmap for success for you. Okay, I'm talking too much. Here's another question. How long is a good amount of time to be on Femara? I was prescribed by my OBGYN after 2 miscarriages, and learning my ovulation was late on day 21 in a 28-day cycle. So how would you answer that?
So I typically say we were prescribed for 5 days.
Mm-hmm.
Okay. Then we have you come back and see if you responded. If it didn't seem like you respond, we might give you another 5-day course and see.
Right.
But in terms of the number of cycles, I typically start off with up to 3 cycles. Right. So I say it depends on their age and again, many factors, but I typically say I think it's worth giving it up to 3 cycles as a shot. They don't get pregnant in the first, we try in the second. During the second, we talk about things. If that one doesn't work, how are you feeling? Because for a lot of people, it's mentally and emotionally taxing. Even though we'll say give it up to 3 shots, after 2, people are just kind of like, no, I want to go to IVF.
Right.
But I think 3 is fair. Then after that, I recommend moving to IVF. But for some people, they're not there yet, and that's okay. We kind of take it step by step, and then maybe 4 or 5, but typically 3.
Yeah, I love what you say. Always talk about what if this doesn't work? What are we going to do differently? And what I tell my patients, if your period starts, think of me. And I actually have a bumper sticker on my car that says, if your period started, follow me. Follow me to my office, because I don't like periods around here. I actually hate them. And then for this woman who had 2 miscarriages, I think it's really important to talk to her doctor about a recurrent pregnancy loss workup, and just don't just assume that, oh, being pregnant, that's great, and just keep trying. I think there's so many like genetic stuff that you can be doing to make sure that it isn't preventable, and there isn't something that you could potentially pass on. So here's another great question, genetic testing question for you. Is PGS testing harmful to an embryo? What do you think?
So when we do PGS testing, we actually take cells from the part of the embryo that doesn't become the baby. It's called the trophectoderm that goes on to become the placenta. There's no harm to the physical part of what becomes the baby. And they've done studies in which they looked at biopsying the embryo and not even looking at whether they were normal or not, and just transferring them. And they show that the active biopsying does not affect implantation rates. Mm-hmm. So overall, we feel like it's safe and it doesn't harm the embryo.
Right. And not every lab is the same.
Yes,
right.
That's right. So, it also depends on like labs that do it very often are going to be inherently better. Right. And so their technique is going to be better. So, but overall, I counsel patients that I feel as if it's safe to do.
Okay, great. This is another question. What are the reasons a baby stops growing after a successful implantation? The sac was growing, but no baby present. That's the question.
So it sounds like when you have a gestational sac, but we can't see something called a fetal pole, that's what I term an anembryonic embryo. So for me, that means that there's something inherently going on that's preventing the embryo from growing and dividing. So it could be chromosomal, or it could be that there's a million things that have to go right within an embryo to implant to become a baby. And it could be one of those mechanisms that, we can't identify. So the majority of the time, I think it's likely secondary to the embryo. It's possible that it's due to the environment, but, more commonly, I would say in that case, it's likely secondary to the embryo.
Yeah. Or the environment too. Like I've seen cases where I did the Receptiva test looking at inflammation after a case like that. And I saw the score was really high, and then I treated them and the next pregnancy was healthy. And it's just hard to know,
Yeah.
Yeah, so hard. Here's another question. I developed OHSS after my retrieval on Thursday. I was on Dostinex and Letrozole, but my doctor wants me to come in tomorrow. Is this just routine, or should I be worried? I bet it's just to check on it.
I just want to make sure you're doing okay. When you have hyperstimulation, you can have fluid that accumulates, and he or she probably wants to see how much fluid do you have. Are you having any trouble breathing? Are you feeling really full? Occasionally, if someone's really uncomfortable, we can remove some of the fluid, and that it might relieve some of the symptoms. Depending upon the stimulation, and the fluid might come back a little bit, but sometimes it can provide some symptomatic relief.
Right. Here's another great question. How many days do you do Omnitrope if you've already done 2 rounds of IVF? I'm 40 years old.
So typically, I mean, sometimes we'll pre-treat or we'll start before the cycle and then we'll
Okay.
continue. And in some patients, we'll start around the same time that we would if, give like a ganirelix or cetrotide and do it for about 5 days. It
Yeah.
just depends on the patient, but
Right.
routinely, more commonly, we give it for about 5 days in our
Right.
practice.
Yeah. I tend to do it every day, every other day in the cycle, and then maybe a little bit before too. It just depends on the
Yeah.
patient. You're right. Okay. If my cycles are 38 days long and I take an ovulation test and it's positive, is that accurate? Am I ovulating?
If your cycles are off, so the menstrual cycle consists of two parts.
Mm-hmm.
The first part is what we call the follicular phase, the amount of time it takes to grow an egg, right? And then once you ovulate, that's when that LH predictor kit will go off. And the
Yeah.
second part, the luteal phase, which
Yeah.
is pretty much constant, 12 to 14 days for everybody.
Yeah.
So if you have a 38-day cycle, I would say that you're ovulating around like day 24 about. So
Yeah.
if your ovulation predictor kit goes off at day 10, that doesn't
Right.
necessarily seem accurate to me.
Right.
So I would argue that you're not necessarily ovulating. And
Right.
sometimes in women who don't ovulate, that hormone that we're looking for, LH, is just high at baseline.
Right.
So if you do it, you could have a false positive. So I'll have somebody saying, I did it for 6 days and it was positive
Right.
for 6 days. What does that
Right.
mean? To me, that just means that the level that needs to trigger it to be positive for you is your baseline level.
Right.
What you need to see is a surge. And
Right.
those ovulation predictor kits aren't going to catch your surge because your baseline level, it thinks is a surge.
Right. Okay. Here's another question. Question for you. How many days post 5-day transfer do you check pregnancy tests?
Between 9 and 11 days.
Okay. What is the lowest HCG post 5-day transfer that you've seen turn into a healthy pregnancy at that stage?
At 9 days, I would say I've seen 40 or so. I mean, we see everything, I think.
Oh, okay.
I
Okay.
think I would say about 40. Yeah.
40.
We like to see ideally 70 to 80.
So
At 9
40
days
at
either.
11 days or 40 at 9 days?
40 at 9 days.
40 at 9 days. Okay. So
Yeah.
the question is, what are your thoughts on late implantation after FET? And I've seen some crazy cases where the first HCG was 15, the second HCG was 15, the third HCG was 30, and they delivered a healthy baby.
Yeah.
Yeah. So the lowest HCG that I've seen turn into a live birth so far, 8 days post transfer, has been 13. But I'm hoping pretty soon I can say that it might be as low as 9. But we'll see. I'm following something very, very closely, and I'm hoping to have a great success story out of it. Okay. So here's a genetic question. We're almost out of time. We've been doing this for almost an hour. And so thank you. We have so many more questions to go through. So will you come back again? I think we need you back to answer more questions. Okay.
Yeah, you tell
good.
me.
And next time we'll get you a tripod.
Yeah. Yeah. No, I have one. I just didn't set it up. Yeah.
I'm just teasing. Okay. My husband and I, because I need some Zofran at this point. My husband and I are both carriers for alpha thal. And after talking with a genetic specialist, we decided to move forward with IVF without PGD. What would you suggest?
That's a good question. So it depends. So alpha thalassemia is a form of anemia that can significantly affect offspring. And so it's what we call an autosomal recessive disorder, which means, as you may know this, that you have a 1 in 4 chance of having a pregnancy affected with that disorder.
Yeah.
So we got a 75% chance that you don't. And so for some patients, they'll say, even though we would much rather get pregnant and have a baby affected with this disease than possibly not. And so I just think it's a risk-benefit analysis and what you're comfortable with. There's always the option to test while you're pregnant and use that information to make a decision. Some patients will decide to continue the pregnancy knowing and use that once the baby's born. Some patients may decide to terminate, but I think that's fair. As long as you understand the risk benefits, I think it makes sense.
Right. Right. Thank you. So I'm going to just finish this off. One last question. And the last question here, I'm just going to go to the last one. We skipped about 4 or 5, but I'm just doing this because of time. So you guys, if you added your question and I didn't answer it, please message me so that I'm sure to answer it next time that Dr. Sachdev is on. Okay. So please, please, please don't forget to do that because she's such a delight and I love having her on. So the question is, what is the normal estrogen progesterone level 3 days post ovulation?
So 3 days post ovulation, I expect to see the progesterone 3 or above. And the estrogen, so your estrogen is going to rise, but then it's going to drop also. So 3 days, that varies from person to person, depends on the number of follicles. Right. Typically, it'll probably be around 90 to 100 or above, and your progesterone will probably be 3. But for some people, like it won't be 3 until
Yeah.
4 or 5 days later.
Right.
So it's a hard answer, but yeah, your progesterone is going to be 2 or above probably,
Yeah.
and your estrogen is going to be a little elevated.
Yeah, totally. Okay, cool. Well, thanks, Nidhee. It was so fun to have you on. Thank you again for joining us.
Yeah.
Thank you, everyone, for joining us today. We're going to have her on again, probably the next week or two. I'll talk to her offline to figure out a great time for her to come back on. And thank you guys for joining today. You guys have been a great audience, sending in lots of amazing questions. And I hope whoever's listening to this learned a lot, and come back next time. Okay. Thanks, Nidhee. Have a great night.
Okay. You too.
Bye-bye.
Okay, bye, guys.